Hi everyone, this is Dr. Yvonne Kamal. We're really honored that you guys have joined us. So I think that there's people who are joining us from Kenya and all across the US, multiple states represented. So I just want to welcome everyone that's joining. Thank you guys for being here. So with all of the publicity around COVID-19, there's been a lot of conversations about the COVID response with lots of new information coming out every single day. So our objective with our time today is to hear from voices in the front lines, hear their stories, get some personalized insights from their experiences, fighting the flames from the front lines. And I think that this is a true privilege because we're gonna get a chance to really understand what their journey has been like thus far. So thanks again for being here. So as we get started, so a couple of housekeeping rules. So this is a recorded call, and this just gives us a chance to share what our discussion with other members of KEDU and also to the general public community that might be interested in some of our conversations that are ongoing regarding the topics that we select for the webinars. So the other thing that I wanted to mention is the questions that have been posed today have been fielded from the medical community. So they're specifically questions that the medical community is interested in learning more about. So thanks for all the people that did contribute to those questions. So I'd like to also recognize some of the leadership team, the KEDU leadership team that's currently on the call. So we have Dr. Christine Garuya, who is the founder of KEDU, and we have Dr. Mioka Maina, Dr. Jimtai Mungo, and also Dr. Stephen Kimani. So thank you guys for being here and for joining us. We're honored to have you. So quick announcement also, before we proceed, is during the last call, we had a lot of interest in some kind of mentorship program, a place where people who need advice on different topics can get someone who will hold their hand and kind of walk that journey with them. Whether you're trying to navigate learning about USMLEs or learning about what is it like to practice in the US, and also vice versa, what is it like to practice in Kenya? There's a lot of interest and people want to learn. So we decided to create a mentorship program. And if you go to kedu.org, kedusa.org, sorry, so that's kedusa, KEDUSA.org. There is a mentor sign up and also a mentee sign up, so we can get to know you, learn what topics that interest you in terms of mentorship and what interests you in terms of getting a mentor as a mentee. So thanks again for checking that out. So the next thing, I'd like to mention that for this webinar, we're partnering with Medixus to host this webinar. And Medixus is a knowledge sharing platform that's creating a Pan-African medical community. And as I proceed, before I proceed to the questions, I'd like to invite Jean Muigai to kind of tell us a little bit about Medixus and their role and what they're doing and what they're all about. So welcome, Dr. Muigai.
Thank you so much, Dr. Nyakeo. Thank you to the KEDU team. As Nyakeo said, my name is Jean Kula Muigai. I'm one of the directors of Medixus. I'll just introduce my CEO, who's also on the call, and she'll give you a quick spiel about what Medixus is all about. So welcome, Nicole Kyoto, who's the CEO of Medixus.
Hi, everyone. Thank you for the introduction, Jean. Thank you. So yes, as Jean mentioned, I'm the CEO of Medixus, and I'm really excited that we're hosting this webinar together with KEDU. At the core of Medixus, for those of you that haven't heard of us, what we do is exactly this kind of knowledge sharing every day, but in our mobile app. So we're trying to support the COVID response by posting daily updates about the latest guidelines, digests, best practice, but also providing a way for medics across Africa and the rest of the world to connect on patient cases, collaborate in real time, share learnings. So what we'd really encourage you to do at the end of this webinar, if you'd like to keep talking to each other, maybe on an individual case-by-case basis or sharing learnings at a higher level, to sign up to the app. We've got over almost 800 doctors there across the world, predominantly in East Africa, where we're primarily operating. So yes, that's a quick spiel about us. So we're really glad to be here. Thank you.
Thank you so much for that introduction, and thank you to Medixus. We are honored to partner with you on for this webinar. So I'm going to just dive right into the conversation by first introducing our wonderful panelists. So first, Dr. Paul Mbuvi. He is the deputy head in the Accident and Emergency Medicine Department at KNH, which is Kenyatta National Hospital. And Kenyatta National Hospital is Kenya's largest public hospital, just for those who are not familiar with the medical landscape in Kenya. Also, he is currently at the forefront of Kenya's COVID response at both Kenyatta National Hospital and Mbagathi Hospital. He has first-hand experience in managing the crisis from a patient care and staff safety perspective. Also on the call is Dr. Marybeth Maritim. So she's a tropical and travel medicine specialist, and she's also the senior lecturer at University of Nairobi and also at Kenyatta National Hospital. She's a member of the Infectious Disease Society of Kenya as well. She is a thematic head in the unit of clinical infectious diseases at University of Nairobi. And also, which I think this is quite interesting, she's been actively involved in the development and dissemination of COVID-19 case management guidelines across Kenya with regards to COVID research protocols and things of the sort. So again, welcome, Dr. Maritim. We're honored to have you. The other person on the call that we're really glad to have on is Dr. Ben Wachira. Dr. Ben Wachira is an assistant professor of emergency medicine at Aga Khan University, Nairobi, and is also the current president of the African Federation for Emergency Medicine, which is an international association aimed at supporting emergency medicine care development across Africa. Also the founding director of Emergency Medicine Kenya Foundation, which is an organization dedicated to ensuring timely, accessible, and quality life-saving emergency care in Kenya. So I would like to welcome Dr. Wachira as well to the call. So thank you for being here with us today. We are honored to have you. I guess I'll just get started by going to the first question that we have. So one of the things that people are curious about from our panelists today is what it is like for you from a clinical perspective on the front lines. How has it changed from what it was before to what it is now? And maybe we can go to Dr. Mbuvi to get us started on the conversation with regards to clinical care at the front lines.
Okay. So how the clinical, there's been a change in the clinical aspect of basically practice. Like you said, I worked in the accident and emergency department for quite a while before the COVID situation began, and I was moved to our Mbagathi IDU facility and also working at the KNH IDU facility. Now, what I noticed was that the change in our clinical approach, not just for us as the people in the, working at Mbagathi, but now from other colleagues in other hospitals, is that the whole COVID thing has become quite a scare to people. So any patient who comes in with running nose or a cough, let me specifically use the issue of cough and maybe difficulty in breathing. There are so many differentials to that. But by the fact that now COVID has become like the first thing that comes to someone's mind, some of the cases that we have been receiving at Mbagathi have been actually sent by our colleagues who have just taken a deep history of the patient and decided this patient sounds like a suspect, we need to send them to Mbagathi for screening. Despite that, we get patients who, let's say, have patients are known to have hypertensive heart disease or CCF, and they present with features of maybe of acute decompensation, and they're still sent to us by that on that basis alone, that these guys are having a cough and difficulty in breathing without actually evaluating what else could be the reason to this patient's deterioration. Let's put it like that. And for majority of these cases that we have seen, even after we do the COVID testing, they've actually come back negative. So these patients have had to be taken back to now Kenyatta Hospital now for them to be taken care of now by the team that is there. So that's how the change has been. There's a lot of pushing of the patients rather than actually patient's history, trying to figure out what else could be the cause of this the cause of this patient's deterioration, except now everything is just COVID, thanks to them. That is the most I would say.
Thank you for that overview. I think also I'd like to maybe see what Dr. Maritim's perspective has been on the front lines from a clinical perspective, and also from like a protocol standpoint and setting the guidelines there in Kenya. Welcome, Dr. Maritim.
So good evening, everybody. Thank you for this opportunity to join the panel discussion. I hope you can hear me. I hope I'm not freezing because I see a sign sometimes my internet is unstable. My perspective has been slightly different, and it's good to have Dr. Mbuvi on the panel as well to share frontline experience. So COVID has changed our lives really, because we watched the outbreak unfold in different parts of different continents, but we never thought it would actually reach Kenya. So we knew it would come, but it came sooner than expected, and from that time our lives have changed. So our routine work was disrupted. I teach at the University of Nairobi. We had to close the university unexpectedly. And I remember when the first case was announced on a Thursday, on Friday, the students, we had planned a teaching, and we all agreed that we were not going to have the teaching because we were all scared to go to the hospital. So from that time, our lives really changed. So my perspective really on the front line has been slightly different.
Just real quickly, I want to, we're having some background noise, and I want to make sure that everyone can hear really well. So I'm going to ask everyone to be on mute, and also just to make sure that we can all hear the conversation. Carry on, Dr. Maritim. Sorry for interrupting there.
Okay. So the first case was announced. We were called to the ministry, 3 of us from the University of Nairobi, and we were called into the National Task Force committee at the ministry. So there's a higher level committee that was formed by the president in February, late February, 28th of February. It's called the National Emergency Response Committee. But below that, there's force within the Ministry of Health. So we were co-opted into the task force. So initially working like every day, we have a lot of face-to-face meeting, and we're co-opted by reality. The outbreak became a reality, and we had to put in place a lot of systems to help start the response program. So we had to develop the case management guidelines. We had to work with other teams to see how the lab testing will be.
I think we might be having some connection issues, Dr. Maritim, on your end. Well, I think as we're waiting to get Dr. Maritim back, maybe perhaps we can get have Dr. Ashira chime in on his experience on the front lines as well, from a clinical perspective, from an emergency medicine perspective as well. Welcome, Dr. Ashira.
Thank you very much, Nicole. Sorry, not Nicole. Thank you very much. I think from our end, I think from the first point that this was declared at the hospital perspective, we pretty much kicked into disaster preparedness, and real disaster preparedness plans were activated. From the department, and that has been, it was just intense preparation, getting all the protocols. So we have our individual set of protocols at all levels. We had to make sure we have enough resources and supplies. So it was meeting after meeting and planning after planning. So it was quite intense initially for the first couple of weeks. From the departmental perspective, I think initially it was a sense of panic, but as we watched the numbers grow or pretty much trickle in, and through a lot of education and demystifying the disease, we're able to set in protocols to get people a bit more comfortable with the cases. So as it unfolded in the West, we were watching it keenly, but locally the good thing is the trend was not as rapid and it wasn't as fast, and the cases just kept dwindling over time. So yes, we were prepared. Yes, there was initial fear. But at least from my team in the AD, we got a bit more comfortable. I cannot say the same for the inpatient teams. They initially actually just boycotted coming down to the emergency department. And they're still boycotting some of them. But I think over time, with the realization that this is our new norm, we've gotten a bit more comfortable and adjusted our protocols to be able to comfortably settle into this new norm. So we've had a few cases show up in the hospital and successfully left. And that, I think, has also built the confidence in the institution. But yeah, so far it's been a learning experience in terms of how quickly you need to get prepared, how quickly you get your resources in place, but also having to deal mainly with the human factor, the staff, making sure the staff is comfortable, making sure the staff understand. People were in tears at some point, not really wanting to be at work. So dealing with those aspects of it. So the human aspect has been quite an interesting perspective to make healthcare workers more comfortable to look forward to going back to work. So that would be my take on it.
And that's something that just has stuck with me, is the fact that we're now in a new norm in terms of healthcare response from a clinical perspective, both inpatient, outpatient. So I'm curious, I think we've gotten Dr. Maritim back. I'd like to maybe pose this next question to you. Would you say, like, in your experience, are there myths that you need to dispel from a clinical standpoint about COVID-19 that, especially in Kenya, or even that maybe might be different from the US, but I think that's one thing that people are dealing with a lot. Just a lot of myths, false truth, misinformation. And what are the common things that you're seeing that people are perceiving about COVID or what's going on that are requiring you to take a stand and dispel those false truths?
There are several myths that people have and some false beliefs. And one of them is many people feel that COVID-19, I think after the first case was announced, and then we had several cases, the population went, like, the reaction was palpable. People disappeared from the streets. The streets were like how you drive in Nairobi during Christmas. People were nowhere in the city. People stayed at home. But over time, it's like people have come back in a full swing. So many people have since believed that COVID is not a very serious disease. And even the announcements, daily announcements by the CS, when we say many of the cases are asymptomatic, and we've even seen video clips of people sharing videos from quarantine and saying, oh, I was diagnosed, I don't have any symptoms, I feel very well. We know that majority of our patients are mildly symptomatic. But the general belief now is that COVID is not a very serious disease. When the first patient was discharged and she was narrating her experience of being diagnosed, being managed, surviving COVID, many people actually thought that COVID is like a glamorous kind of disease, so to speak. So people have not taken this disease very seriously. I think when we initially saw the video footage from Italy, from China, from New York City, people respond, but the response is temporary and people quickly forget. People have become very impatient. People are tired of being confined, and now you find we are throwing caution to the wind. People are coming back out of their houses. When you walk on the street or when you're driving on the road, you see some people without even their masks. You'll see people with masks that are hanging over the chin. Some people actually don't have masks. So if they're not wearing the masks, the next question you ask yourself is, are they even doing hand hygiene? Because all these interventions, they work well when they're combined together. Social distancing, when you watch the videos of what's currently happening in Italy, what has been happening in Mombasa, there's definitely no social distancing. And those are places where we currently have active community transmission of the disease. So that makes us actually get very scared, because the disease is definitely being amplified because close proximity of people who are not even adhering to in intervention. So that is one of the beliefs. Many people, we haven't seen a lot of cases. We haven't had a lot of mortality in our part of the world. So people have lost the fear that they had initially. And when you read even in a lot of the WhatsApp groups that I am part of, many people are very frustrated. They feel that the government interventions that have been put in place are too harsh for a very mild disease. But to me, this is very unfortunate because the disease transmits quietly. The disease, majority of the people who transmit the disease are people who are mildly symptomatic, are asymptomatic, and no one will tell you. When you meet someone who's infected, they'll not tell you I have COVID so that you run away from them. So the disease will actually transmit actively in the community, and then now when you start seeing the cases, what you're calling the surge, these cases will now start to present to the hospital without warning. So the people have thrown a lot of caution to the wind. They are not listening to the government, and actually it's like, no, you have on one side you have the government, on the other side you have the people, but we are not meeting somewhere in the middle. But just to emphasize that COVID is a very serious disease. It still remains very a serious disease. And one of the unfortunate things, again, a lot of the people even who are questioning how serious COVID is a lot of our colleagues, because we initial models had actually predicted that we'd have 1,000 cases by around mid of April. We'd have 5,000 cases by end of April, and we'd even reach 10,000 cases by early May. Those numbers haven't come to pass because most likely the interventions that have been put in place by the ministry have sort of worked by the ministry and government in totality. So the fact that the numbers haven't come has caused even a lot of doctors to become restless, because by the restrictions that have been put in place, patients are not presenting in hospitals, people are losing income, source of income is depleted, so to speak. So people have become very restless, and even people who are very educated, who know about the disease and the consequences, have lost faith in all the interventions that is being done. And this is too early in the outbreak to actually lose faith in the interventions.
Thank you very much, Dr. Maritim, for that perspective. I'm curious, in case, let's say we sort to numbers that we're seeing, like similar to the ones that we're seeing in New York and like we saw in China and Italy and the like. I'm curious whether, maybe we'll start with Dr. Mbuvi on this one. Do you feel that Kenya would be in a position to manage the crisis should the numbers rise to those levels? Thankfully, they haven't based on predictions, but if that was to happen, what are the challenges that you might foresee, opportunities that you might foresee with the response?
So from what we have seen so far, it's true, the cases have not been as bad as it had been projected before. The government interventions, I believe, have actually worked in keeping those numbers at a smaller size. Now, the thing is, like in our facility right now, the Bagati IDU is that we have a lot of asymptomatic patients. These patients are COVID positive, but they're asymptomatic. They're walking. The only issue that they have currently right now, it's mostly joking and asking why we have delayed their lunch or their supper and why the food is cold and such things. So, given that we're actually now dealing with just asymptomatic cases or patients of mild, let me call them mild symptoms, it's been a bit of an easy, if I can call it an easy ride in a way. We've not had in the Bagati facility, we've not had any patients who required like critical care to be addressed. But given that now we're beginning to see this rise in numbers, this surge that is coming, as KNH, what the hospital has done is, number one, we've increased the number of medical officers who are currently deployed at the infectious disease unit. We initially started with around 6 medical officers, but now our capacity has been built up to around 15, and we expect to get around 20 to 25, so that we can have that capacity. We're also increasing the number of nurses that we have, and also the other healthcare workers that are needed to run the IDU facility. Number two is that when now we begin to see these cases of moderate and critically ill patients, we need to also factor in that we need intensive care for these patients. Majority of them may require intubation, as has been the cases in the European nations that we've been seeing, and also in America. So what I've done is that we had one of our IDU facilities that is located at Kenyatta National Hospital. It used to be an isolation facility for other infectious diseases, but now it's been completely refurbished and it's been turned into a critical care unit, basically an ICU, with at least a capability of having at least 10 ICU beds at that particular place. And this unit is ready, it's functional, we have the equipment, we are ready to deal with any cases that we get that may actually come in and require intubation and require that kind of critical care. We also have we also have specialists who have also been brought in. We have infectious disease specialists who have been brought in, including a pediatric infectious disease specialist to deal with the children that we have. We have support from the critical care unit from Kenyatta, Domain Hospital at Kenyatta. So they also help us now with the running of the IDU CCU that has already been put in place. It may actually be something, looks like it may be something of a long haul. And given the numbers on my experience on what we have seen at Mbagati is that if we continue having the patients who are coming in, and our demographics is basically very, I'll call them the youthful, between the ages of 20 up to 49 have formed the majority of our patients. And given if this trend continues, we can we continue maybe seeing more of mild and moderate cases. And then as it progresses out to get more to the severe cases, it means now we have to think of a way of how to deal with patients who are mild or asymptomatic, either have them being isolated at a different facility, another place where the government can come up with, so that we can leave the hospital itself to actually be available for the severe cases that may be coming in. So that's where we are as ANH. Those are the kind of mitigation steps that we're putting in place. We are trying to see how we can make it go a bit better. Yeah, thank you.
Thank you very much, Dr. Mbuvi. That is, I think, it just gives us an idea that, you know, as a medical community, we are trying. We're making every effort we can. And I think there needs to be more stories of what we're actually doing and the efforts that we're actually making versus criticisms of what we're not doing. And I think then that helps us, I think, helps the conversation. It actually helps paint a more accurate picture of what's going on the ground. So thank you for giving us that perspective. Just real quickly, I'd like to just pause for a second again and welcome all those who have joined us. We are glad to have you. I'm glad to share that there's about 150 individuals who signed up to be to join this conversation today. So we are glad to have all of you. Notably, we have partnered with Medixus to host this webinar, and we're honored to partner with Medixus. As KEDU, Kenyan Doctors USA, we also have partnered with Medical Students Association of Kenya, and we have some medical students on the line from Kenya, so welcome to you guys. And also we partnered with KMA, which is Kenya Medical Association, and these doctors that have connected to this conversation through KMA as well. So thanks again for being here. And we're gonna just go ahead and move on to another question that I think is interesting to ponder. So it's no secret that healthcare in Kenya is vastly underfunded, and the COVID crisis only serves to illuminate some failures in prioritizing healthcare on a national agenda, for example. So what would it take to get the Kenyan government to allocate more funds to healthcare and health and welfare of its people? And Dr. Ashira, maybe I'll pose this question to you. Do you think that COVID could be that catalyst that can influence funds in that direction?
Thank you very much, Yvonne. Yes, in theory, yes, it should be the catalyst that highlights the gaps and the vulnerability of our healthcare system. Because the reality is, right now, if we were to receive the cases that they're seeing in the US, in New York, in Italy, our system would be completely overwhelmed, completely in a disastrous kind of way. So pretty much we are sitting ducks in terms of a COVID pandemic, and we do not have the resources that it would take to manage the cases that we are seeing out there in the thousands. And this extends from just emergency and critical care services and even mortuary services. I'm not sure how well our system would cope with 1,000 deaths a day. So I think it's a good point where the government needs to really look at how vulnerable the whole healthcare system is to such a pandemic where we're dealing. I mean, we've dealt with multiple pandemics, and many of the times the outbreaks has never really evolved to needing a lot of the critical care services. So this is the first, I'd say, well, in my lifetime, it's the first pandemic that pretty much illustrates how vulnerable we are with a limited capacity of critical care beds. If we are headed, as Dr. Martin was saying, we are headed where the numbers are going to rise significantly, then it's going to be terrible. And I think it's a good opportunity for the government to start looking at how best to build on the healthcare system to address mainly around emergency critical care services, and also just look at other aspects of the healthcare service.
Thank you very much for that insight, Dr. Ashira. I do want to mention that if there are questions that you still feel that are burning questions from the listening community, I'd invite you to go ahead and post them in the chat so that we can, we may not necessarily get to them during the call, but what we'd like to do is start a conversation on our discussion forums that will be powered by these questions, and our experts can respond to them as well. So please feel free to post any questions that you have in the chat as well. So again, I'm curious now, because I think we've talked a lot about the macro level clinical responses and guideline setting and things like that, and protocols and things like that. So what I would like to kind of ask is, let's say we'll start with Dr. Mbuvi. Do you ever find yourself thinking about your own personal exposure? And I'm also curious from all of the docs who are on the panel, do you worry about your own exposure, and what keeps you motivated? What makes you show up every day in service to the people? So let's get started with Dr. Mbuvi.
Okay, thanks for the question. What keeps me motivated? I have to say, first of all, we have a very strong team that we work with at the Mbagathi facility. We have a very good coverage from the consultants. People actually really do care about the frontline workers who are there. And the hospital itself has actually put in place certain things to ensure that we are actually comfortable when we go to work. So far, since we started when we started having the first cases, when Mbagathi now started having patients who are coming in for triage, which was around 13th of March, we have, up till now, there's not a day that has come where I've lacked having the personal protective equipment that I require in order for me to see the patients, and this has been facilitated by the hospital itself. So they give us that opportunity, and even when you look now at other external things, like what other companies are coming in to do in terms of support and bringing in PPEs for us, and also if I can give an example, there's a hotel that actually brings for us lunch every day, and that allows us as a team to have lunch together and actually bond and talk about our experiences, and it keeps us forming that teamwork that we require to inside there. Because what we realized was that at this point, when you're in an infectious disease unit, there's no one who is above the other person. There's no that doctor, I can only do this, or I'm a nurse, I can only do this. When you don't in that PPE and you're actually inside there dealing with the patients, it means that you can be at any time. I can be the one taking the blood pressure, it's the work of the nurse. Or I'll be there assisting them, maybe in doing bed making. If we are two of us inside there and the linen is there and I'm already donned, there's no point of us asking someone else to put on PPEs, come inside and to do this work. We can all be able to work hand in hand and do it the way it's supposed to be done. The other thing is that, yes, we do get scared. There is that part where you feel that, yeah, what happens to me if I do get exposed? Will I need to have quarantine? Will I be isolated from my family? Which is basically what happens to the patients who are in the facility. At that point, what Kenyatta has done is that for any person who gets exposed, Kenyatta already has a contingency plan of how to deal with it. Well, we already have hotels that have been identified that will work as our quarantine sites, and we also have they recently opened up what you call the daycare center. Well, not really a daycare center, but one of the buildings in Kenyatta was converted now to become a place where any confirmed healthcare worker can be admitted. So we have a facility where we can admit any healthcare worker who gets COVID-19. They can have a place where they can be. It's a good place. It's well put up. It currently has a capacity of around 24 beds. Has some private rooms as well. So at least there are those things that are happening. So as you keep going to work every day, having that support from your teammates, having that support from your consultants, having that support from now the hospital organization itself goes a really long way in helping us to keep doing what we're doing on a daily basis. Yeah, thank you.
Thank you for that perspective, Dr. Ngugi. Really important perspective, because we're physicians, but we're also human beings as well too. And we've taken an oath to serve people, even if it means putting our lives at risk. And I think that's the calling of our profession. So thanks for sharing that. I'd like to maybe perhaps Dr. Maritim and Dr. Ashura can chime in on the same question with regards to concern about your own exposure. I guess maybe also another question that can tie into that is, has life for you shifted, especially when it comes to like personally, professionally, how you engage, if you engage with your loved ones, things like that. Maybe you can give us more of a like personal perspective on that. Thank you, Dr. Maritim and Dr. Washira.
I'll just share my perspective on the risk of exposure and what that means and what keeps me motivated. So when I think of the risk and the exposure, what gives me consolation is that we have watched the outbreak, we have seen what happened in China, and there was a lot of things that were not known. So in Africa, we are very fortunate that we actually have a lot of information to help us protect ourselves. We know that PPE is effective in preventing COVID-19. So even sometimes as healthcare workers, maybe the risk may not even be from the hospital. The risk may be higher even in the community because of what people are doing in the community. So we should not forget that. But many a times, like when my family call me, like my parents, my mother, my close friends, they're always praying for me because of being in the front line. So one of the things I have taken personally is really to champion at the highest level, because of my role in the National Task Force, is to champion for PPE as a bare minimum for healthcare workers. And we've had the CS repeatedly, we've had the PS of Health repeatedly emphasizing that really this is a major like requirement in terms of fulfilling obligations to enable the frontline healthcare workers to do their role. So in the initial meetings, many people did not understand what exactly is PPE, why are you emphasizing the role of PPE, what is it? And many people were trivializing. And I remember one of the meetings, the committee that was looking at mobilizing resources to buy the PPE, they actually, I think the initial cost of PPE had really jumped up significantly because of the shortage. So they wanted to sort of like buy PPE, and there were these photos of the doctors. I think these were the Italian doctors, and you could see them wearing the waterproof surgical gown, and they're asking, look at these people, they're not wearing the overalls, the jumpsuit, the hazmat jumpsuits that is available. Can we buy this instead of this? And we said, no, we've already put the requirements. This is the minimum if we want the healthcare workers to go and face the patients. So that really has given us encouragement that the government listens and the government is doing the best it can to procure the right PPE without compromising. And in some cases, even when you have situations where you hear that healthcare workers don't have PPE in the facility, so we had to talk to the level, you know, like the MOH, because they listen to us a lot, to say that if we have dedicated isolation facility and we already have cases in certain counties, if there's a shortage of PPE in the country, then it's best to move resources to those counties that already have cases, because you don't want to put healthcare workers to be in a situation where they have to make a decision and go and see patients without having any PPE to protect themselves. And we increasingly have had more PPE. We've had the local production of PPE, and this is very encouraging, and this is what keeps me motivated. We have just, the ministry is in the final stage of developing a guideline protocol for human resources for health, which is a comprehensive document that sort of puts into perspective, like, how do you protect the healthcare workers? What trainings are required inside there? How do you, what PPE, what other compensation should you do for healthcare workers? How often should you test healthcare workers? And that will be launched fairly soon and will be available to provide guidelines, because in Kenya we have the devolved healthcare system. So sometimes these two governments maybe don't talk too well, But once the human resource for health guideline is developed, then it will be shared out and sort of disseminated. And inside there, it sort of gives guidance on even the working. Dr. Mbuvi maybe did not mention this, but they have shifts of how they work, how their time offs are, like how many weeks they spent working, how many weeks they spent being away. So all that we're trying to harmonize and develop a protocol that will sort of provide guidance so that there's uniformity in all the facilities across the country. I'll stop there.
Thank you very much, Dr. Maritim. Really, really appreciate that perspective. So I think that we actually are getting a lot of great questions coming in. Before we delve into a couple of questions, I'll have Dr. Washira then respond as well to his experience with concerns about his own exposure and how has life changed for you.
All right. So for me, I think, am I concerned? Not really. I think I work in a place where we've gone overboard in trying to make sure that we're all safe, and we've been provided with the resources that we need. A lot of what I do involves also looking at the data, looking at the science, and we have a whole team of scientists who discuss on a daily what is to be done and what levels of protection and things like that. So I think, and then again, also being part of the task force that leads the hospital, then we also have to be able to make sure that the teams below us are very comfortable. So that has been our biggest objective, to make sure that people are comfortable within the institution managing COVID patients. So I think personally, I mean, I go to work every day. It's been normal, too much work actually at some point. So I'm not really concerned based on where the data is at the moment, based on where we are at so far. Of course, naturally, this is numbers that we're keeping an eye on, where as soon as we start seeing anything change from what is the current situation, then we may potentially start panicking. But for now, I think we're in a good place, and our focus now has been more about returning to normal. And even at an institutional level, is how do we go back to normal in this abnormal scenario? So yeah, so I think, yeah, life has been normal, a bit much work, but been fairly normal. Yeah.
Thank you, Dr. Ashira. One of the questions that's come up is with regards to psychological counseling and support, both for healthcare workers, patients, and also families. And I think maybe there's somewhere where I saw there's a hotline for getting psychological support, and this was in Kenya, which I thought was really amazing. So I'm curious whether you are aware of psychological support at your facilities, thinking also about that. Anyone can respond.
So we offered, I mean, there's a national psychological hotline that's being offered by Kenya Red Cross. That's a 1199 number. Mm-hmm. Within the hospital, there was psychology and counseling team or started off a hotline, and then an online stress assessment, so that you can actually do your own stress assessment. And I think the link is somewhere. Then once you do that, and if you feel that if you score on certain aspects of stress, then the psychological team, they've been actually very helpful. They've been part of the committee, and this information has been disseminated and they've been accessible. So I think that has also been part of the help we've had as an institution to keep people stress levels a bit down.
We actually ended up learning the hard way that we actually do require psychology counselors in our unit, and not only just for us as the doctors, but also more specifically for the patient. This has been one of the challenges that we've had, given that we have to stay in the facility for 14 days for isolation, and some of them have actually ended up staying much longer than need be. Okay, not that need be, but they've stayed longer because the repeat testing actually ends up coming back positive every time. We've had several patients who have stayed in the facility for actually more than a month. The longest stay there was 32 days. And it became quite apparent that these people need to have someone to them, someone to brief them, someone to just find what's going on about in their lives at that particular point. One of the patients that we had was a Cameroonian national, so none of his family members were around in the country. He was actually caught in transit at the airport, and he was found to have fever, brought to a facility, and once he was tested, he was found to be positive, so we had to isolate him in the facility. And his stay there had been quite dramatic, given that there are many times he used to break down and cry and ask us why he was still keeping him there, why do we not want him to go back to his family. And it was it had become a very trying time. But now we have counselors who come to see these patients on a daily basis, especially the patients who we bring into the facility the very first time. Even the suspected cases that we have who are waiting for results to come out, we have them have a session with the counselors so that they can actually be told about what COVID-19 is all about, what things that they need to look out for, how the mental health is, and such things. And so for the confirmed cases, now that we now have cases where we have entire families isolated in our facility. You'll find a mother, the father, then the kids are also there. So they're all COVID positive, but they're all asymptomatic. So they're just staying there and not really doing much. That has been the aspect of caring for the patients. For us as the healthcare practitioners, we usually have a debriefing session every week. It's usually done on Thursdays or Fridays, preferably usually in the morning hours. So anyone who feels like they need to come, they actually come. And if you feel like you need to have a one-on-one session with the counselors, that is also arranged, and actually a very easy process for us to do, because the counselors they're actually in-house. So they're there every single day. If you feel the need that you need to talk to them, that has been part of the thing. The other thing that we noticed was that now having patients who are just quarantined in a facility without anything much to do tends to put them in a certain mood. Some get angry, some get depressed. And so the facility actually ended up having to get Wi-Fi for the patients, so that at least now they can have some form of access to the internet, at least maybe do some reading, go on social media, just something to help them to de-stress and just ensure that their stay in the facility is actually it's taken care, it's bearable at that point. The good thing is that when we actually see these patients leave the facility, when now they've received the 2 negative tests and they're leaving the facility, and you can actually see the joy that they have. We also have the same joy because we feel like we've been with you. These people, especially the long-term clients, have now become like our family. And when you see them leaving and you feel, yeah, at least now you're leaving, you're going to a place where and that the stress levels will actually be reduced and things like that. That has been our experience with the psychology and counseling aspect of patients. Yeah, I think I'll stop there.
Thank you very much, Dr. Mbuvi. That's really great insight into those relationships that you build with your patients. And you can't really help it because we are all human again. So now the last question, again, let me just say we are getting a lot of really great questions, and thank you for your questions. And what we're going to do is continue the conversation on kedusa.org, and we'll send you information on how to do that and how to access those conversations. So as we wind up, I want to direct one question specifically to Dr. Maritim. So there's various sources that have stated that it will likely be months or years until people's lives can go back to normal. I'm curious what your thoughts are on what indicators will need to be monitored in order to ultimately determine when it will be safe again, when life can go back to normal for most people.
That's a very interesting question. And the plain answer really is we don't know too much, because it's difficult to know what will happen in the near future, in the distant future. But in summary, really, we are watching the numbers, we are watching the outbreak evolve. And this disease is new. We've had other coronavirus outbreaks in the past, the SARS in 2003, the MERS-CoV in 2015, and both these infections actually finished on their own without much interventions. And actually, some of the drugs even that were being tried could not be completed. The clinical trials could not be completed because the cases disappeared. So for this one, and that's why even as we prepared, we probably thought that the disease would never come to Kenya, because in the past, like all diseases would come in the neighborhood, other continents, but would never reach Kenya. So for and it reached, we're watching the numbers. We don't know how it will spread. Some people have said maybe.
I think we were having a bit of background noise, and also I think some connection issues.
When we look at the
yeah.
Okay.
Yeah.
So like I was saying, we have watched the number of cases in Africa, and there may be something that's protecting us, because people who are saying the magical time is around maybe the second month, day 45, and most countries have passed their day 45. The cases are still increasing, but we haven't seen an exponential number of cases. So it's a steep rise. In Kenya, most of the interventions that we've put in place are really to flatten the curve, because we know the intrinsic weaknesses within our healthcare system. And we know that our healthcare system will not cope with the cases that we've seen in other settings. So all these interventions are to flatten the curve and to sort of help the healthcare system cope with fewer cases within a given time. So to say how soon we can lift these restrictions, like the lockdowns in the various counties like Nairobi, Kilifi, the coastal counties, as well as Mandera, it's difficult to say what will be that thing that we are looking out for. Whether is it that when we stop reporting cases, the challenge has been, despite the restrictions, we haven't done a lot of testing to sort of give us a general idea what's the incidence of this disease within our setting. So we don't know really what is it that we are looking out for, and we are watching other settings. Like when you look at China, they put in place very sort of like draconian measures to control their outbreak, but they seem to have worked. And they sort of had a daily indication of what are the number of cases they'll be reporting per day to say that the outbreak is totally controlled, and therefore the lockdown, for example, in Wuhan would be set at a certain threshold of number of cases per day. When we look at the US, we've had the outbreak in different parts of the country at different times. And in those settings, what we have seen is that their curve rose up quickly and then declined thereafter. And that's what happens with unmitigated epidemics, because the number of susceptible people, all of them, sort of a large proportion of them, become infected within a short time. And that provides some form of herd immunity to other people who might otherwise have not been infected. And some of the measures like social distancing then brings them far apart from infection and from disease. But the challenge is that when you lift the restrictions, then you bring these susceptible people back into the general fold, and therefore they are vulnerable to develop the disease. And many of you might have heard of like a second peak may be anticipated, like what was seen in the Spanish flu. In our setting, it's very difficult to say. And especially with the amount of movement now that we are seeing in Nairobi, that is just a recipe for ongoing community transmission. And therefore, even the flattening of the curve that we are hoping to achieve may not really come, because now as more people mix, as the disease is spreading within the community, the only thing that you can expect is an increase in the number of cases. So it will be worse before it can get better. What I cannot tell you now is when will it get better. From the modeling data that we have collected and the models that we have developed in partnership with other institutions and agencies, what we have seen in an unmitigated outbreak, the peak is likely to be around September. With the flattening of the curve, the peak is far out around December. So that is just in summary what we see, but our life is not going to be back to normal unless maybe we found an effective treatment, or unless we find an effective vaccine. And some of the strategies like flattening the curve is really to buy time for the healthcare system to adjust, while even the international community is evaluating and looking for treatments, effective treatments. And for Kenya particularly, we've signed up for a clinical trial where we'll be using some experimental treatment to see whether it will ameliorate the outbreak or impact on the outbreak in one way or another. I'll stop there.
Thank you very much for that insight. And I think that's one of the most difficult thing to say, especially when the world is asking is, I don't know, especially for a physician, because everyone is expecting you to give them an answer, because people assume that physicians know and doctors know everything. So I think it's a great lesson for all of us to be able to provide balanced responses and get more comfortable with saying we really just don't know the answer to that question. And thank you for saying that, Dr. Maritim. So I really respect your time. We really respect your time. And I want to thank you all for being here today. We're really looking forward to continue the conversation on kedusa.org, and we'll send you more information on that. So I would like to thank our panelists. Thank you, Dr. Mbuvi. thank you, Dr. Washir, and thank you, Dr. Maritim. You've given us a lot to think about. And this conversation, I think there's so much insight that came from it. So thank you for that. I also want to thank Medixus for partnering with us for this webinar. And notably, Medixus has an online COVID resource center. So I'd like to also let you all know of that available resource that gives a lot of information on the COVID response, the COVID status in Eastern Africa. Also, remember to sign up if you're interested in being a mentor or a mentee to a medicine trainee or in your field of expertise. We are taking in mentors and mentees. So please go to our website as well, kedusa.org, and sign up. And we're looking forward to engaging with you on our platform. Thanks again, guys. It was an honor to facilitate this conversation. I hope that you all have a good evening. In Kenya, good night. And in the US, good afternoon.